Hello, everyone. Welcome back to another episode of the AI Healthcare Podcast. I'm your host, Dylan Reed, and today we are joined with my friend Mendel Erlenwein, who is the founder and CEO of CareCo. He's also the CEO of Previva Health Group. He's the podcast host of the Healthcare Trailblazers Podcast, which focuses on value-based care, and he's also a leadership council member at the National Small Business Association. That's quite the resume you have there, Mendel.
Well, thanks for the intro. Yeah, I don't think the NSBA thing has been active for a while, but the other ones are definitely accurate. So thanks so much for having me. It's an honor to be here.
Awesome. And can you just tell us, like, how did you get into the AI healthcare space?
Yeah, sure. So it really goes back about 5 years ago when I got into care coordination. So I'd been in healthcare for a while. I was doing kind of marketing in healthcare. Didn't like that very much, and so one day somebody that I got to know said, "Hey, I've got this company. It's in the garbage though. if you want to take it over." And I said, "Okay, I'm listening." So basically, somebody had started a company, and it was a care coordination company, but all the actual care was outsourced to a third party company, and um, it had really not that very many patients. It was impossible to scale, and so the guy that started it needed to move on, and so he did. And the original kind of investor that had uh, that had funded the company was left holding the bag. So I got to know him around that time, and he was like, if you want this company, you can take it." So took over this care coordination service based company. And then over the last 5 years, I've been building that. We brought everything in house pretty much immediately. Turned it around, and we've been growing ever since. We now talked about 5,000 patients a month, 30 plus care coordinators, and it's been a lot of fun. And that's a journey that I can go on and on about. And so a little over a year ago, I started thinking about the second. I was one of those that the second chat. I'm not one of those that's been doing machine learning for the last 10 years and 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 such. But the second ChatGPT came out, I was on it. I was using it. I immediately augmented a bunch of my workflows, and so and I was really impressed by it. So I started thinking, what are some of the big pain points that my care coordinators are having, and how can we solve that utilizing AI? And as I was thinking more and more about it, I kind of came to this realization that care coordination is really good at catching kind of the lowest hanging fruit, if you will, of patient needs. So when you call the patient and they're about to go to the ER and you happen to call them right then, you're able to coordinate that they don't end up in the ER. That's fantastic. When you call the patient and they've been trying to get a medication refill for the last 2 weeks, they've been on hold, and you're able to send a note to the doctor and the EHR and get it done. Fantastic, right? But care coordination really is supposed to be so much more. It's supposed to be a relationship built with a patient that you're talking to on a monthly basis, and you're supposed to help guide that patient, hold their hand and guide them towards some specific goal. And that really doesn't happen very often in the kind of care navigation, care coordination, because we utilize very low level clinical staff, because that's the entire value proposition. We can't be using doctors or NPs for this kind of work. It's not sustainable or scalable. And so it doesn't really happen. So I started thinking of a solution, and we came up with CareCo, which is a co-pilot for our care coordinators. And it's been really phenomenal utilizing CareCo. My care coordinators have gone from dealing with 250 patients and super high stress and burnout to 350 patients and no stress, no burnout. And we basically built the brain of the perfect care coordinator that remembers everything and has a bunch of context. And then we give that to our human care coordinators, and we strip down all the tediousness of their entire job, and just allow them to do what they're good at, which is care for their patients. And I think that's really the future of, or at least the present future of, where AI is going to be really valuable, is in these kind of like augmentation roles that take high stress, high tedious jobs and really strip them down to what is the human good at versus the AI, and then allow the human to focus 100% of their energies on those aspects of their job, and allow the AI to focus on 100% on the aspects that the AI is good at, and not intersect each other.
Mhm. Yeah, because you know, it, we're in we're I would argue we're in the elementary stages of just figuring out what the human should do versus what the machine should do.
Yep. Yeah. Um, yeah, and we're in the elementary stages, but it is already pretty evident that there are certain things that the technology is much better at, such as
Mm.
pattern recognition, such as just being able to analyze data, being able to contain a bunch of data. There's no way that even the best care coordinator in the world can remember everything that that's completely effortless for technology. But on the flip side, it's also evidently clear that there's a whole host of things that the human is uniquely good at that technology is not. And specifically when it comes to healthcare, people like to forget that healthcare it's a human enterprise. It's a human, connection. It's relationship. It's human. That's what it is. And until such a time in the future that may or may not come, that AI really flips over that switch where it's completely indistinguishable, which not from like a trick, like perspective, like not that you would think that you're talking to a human and you're really not, you're talking to AI, but there is a strong possibility that in the future we won't care to talk to the AI because it will, my lens on it is just value, right? Like people don't appreciate that patients don't actually care who's talking to them. They just care if they're being helped at the end of the day. And the same way, if you are the insurance company and you're calling that patient, they don't want to take your calls because they don't feel like you're helpful. But if you're their PCP and you're calling them from the PCP's office, they will take your call because they do think that you're helpful to them. That can very well happen with AI as well, where at the end of the day, if you were able to have a 10-second conversation with an AI bot that completely gets you and gets everything that you need done, or you could talk to a human for 10 minutes, be put on hold twice, and you're going to go the AI direction, but we're not there yet. We're very, 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 very much not there yet. And so is that a possibility in the future? Yes, but it's really important, I think, to be really, really cognizant of the present and where we're at right now. So yeah.
Mm-hmm. And it's and you brought up an interesting term, care coordination. I've always thought care coordination meant just the interaction between um, physicians and patients, regardless of what the situation or what the objective is. But it seems like that care coordination is a much more complex term. Could you just expand upon kind of what care coordination means to you?
Yeah, and great call out, because there's a lot of different definitions for care coordination. And I'd say that I like to say that the higher levels of care coordination, similar to what you're talking about, there's more like care management, which is where someone is managing that patient's care. Care coordination to me kind of denotes just where you're executing on a care plan that's already established by a physician. So I'm not at a level where I'm giving any kind of medical advice, any kind of medical diagnosis, and anything. But what I can do is take this plan that's been implemented and decided upon by a physician for this patient and then follow up on it. So in the Medicare world, for example, it's very common for a patient to come in for their annual wellness visit. And part of that annual wellness visit is a very, very, very thorough uh, assessment called a health risk assessment. And that goes through a whole bunch of different mini assessments and puts this big comprehensive plan together for that patient for the year. And then typically that patient would be rolled onto a chronic care management program, which is now a 20-minute-ish interaction monthly with a care coordinator who's now taking that care plan that's been established and just following up on it. Right. So if the doctor said, you should be doing X, Y, Z with your diet, with your exercise, with your medications, and then just going over, making sure you have your meds and making sure nothing's falling through the cracks. And so to do that, it doesn't take a lot of medical expertise. Some people call it even care navigation instead of care coordination, right? But making sure, hey, if we're scheduling those appointments for you, making sure you have your medications. And if you don't, we are able to put that request in for the doctor to get it refilled, right? Triage accordingly. But really your job is to ask the right question to the right patient at the right time so that you're helping achieve a specific goal with that patient, together with that patient that's been outlined by a doctor. So that's my definition of care coordination.
And fundamentally, is there other situations then where that would kind of be necessary, like aside from preventing them from coming back to the hospital? Because that's what I tend to think of when what you just said, kind of making sure that they're healthy and basically that they don't have to come back for another emergency situation.
Yeah, I mean the entire fundamental underlying philosophy behind care coordination is preventive care, right? And so in a fee-for-service world, it's even in, I should say this, in a value-based care world, it's very obvious why you're doing care coordination, right? Because I want exactly what you said. I want to keep my patients out of the hospital. I want to make sure that they are making the appointments that are important. I want to make sure that they have their medications so they don't run out and end up in the hospital. I want to make sure that, their home is safe. They don't have fall hazards and stuff like that. Like, I can ask these questions. I want to make sure that they have help. I want to make sure that we're aware of what's going on with this patient and we're talking to them and we're working with them towards a goal, right? With the end objective being staying out of the hospital. But even in a fee-for-service world, there's many, many different programs that pay like a fee-for-service, function where, for example, chronic care management will spit out a CPT code of 99490 that has a reimbursement of about $62 per patient per month. And so there are ways to make money with care coordination, even in fee-for-service. But even in that world, the only reason why that program is there is because CMS wants to save money. Like, at the end of the day, whoever is paying is going to be the one saying, what can we implement in order to start spending less money, right?
Mhm.
So, that's why one of my biggest gripes with that is this ridiculous copay that's been enacted. So patients still get a copay for some of these preventive care programs, which isn't just asinine, because the entire point of the program is to save the system money. And this copay, even though it's $8 or $16, that's a lot of money for patients to pay every month, and they don't want to. And so 80% of patients don't participate in these fee-for-service preventive care coordination programs because of this $8. And the doctor is not allowed to waive that copay. Otherwise, they start getting into anti-kickback law issues, and looks like they're incentivizing patients for care and stuff like that. There's Stark laws, and so I know this is a bit of a tangent, but it's one of those ridiculous things that we have to change. Getting rid of the copay for preventive care.
Mhm. And you brought up an interesting point about CMS as someone in the policy space. It's just a battle trying to figure out what CMS would cover and what they're not going to cover, from year to year.
Yeah, I mean, CMS is pretty clear about it, and they have this great, physician fee lookup schedule tool that you can do. But the problem is, it starts getting really convoluted once you move into a lot of the Medicare Advantage plans, and a lot of these people that are kind of like co-opting, Medicare initiatives and Medicare funding. And a lot of them don't pay for these programs when officially they do, but they practically won't. But they say they will, and that's where it starts getting really, really, really convoluted. And to your point about CMS, I mean, one of the big issues there is the fact that the administration can change every 4 years, and with that downstream comes changes in strategy and in direction with CMS, and as such, they kind of have like just 4 years to get something done, which is not enough time when you're talking about tens and tens and tens of millions of Americans that you're trying to affect. You need to be able to give, you know, I'd have to look. I'm no analyst of data, but I'd have to think that you have to give a much broader window in order to see some sort of efficacy from some of these models. And instead, what we're seeing is consistently more and more and more models being pushed into the market, which just dilutes the ability for any unique one individual model of showing some sort of efficacy. So it's got to be really difficult. Yeah.
Hmm. And you brought up another interesting theme. Recently on Capitol Hill, they were talking about kind of in the Ways and Means Committee about like the collapse of, I guess collapse is a strong word, but like kind of the decrease of private practices in the United States. Do you kind of foresee care coordination and value-based care as kind of preserving private practice, or bringing it into the 21st century, or is it kind of, are they just very two contrasting themes that need to be looked at separately?
Yeah. I don't know if there's a direct correlation between the demise or survival of you know private practice through the lens of care coordination. I think that um, for for private practices, typically they're out. Like, the thing with care coordination is that it is something that is done much better at scale when done properly. It's very difficult to do it in a small mom and pop, where the husband's the doctor, or the wife is the so many of these beautiful practices around the country where the wife is the practice manager, and they run this practice together, and it's beautiful, but it's very difficult to also do kind of really efficient care coordination. So typically they outsource to companies like ours at Previva Health Group, or others around the country that do that, where we do kind of these care coordination services. And then the larger the system is, they're able to basically have entire smaller companies within their company, which is just an care coordination team. But I will say, I would love to talk about the, it's a great topic, the survival of private practice. I don't think I'm ready to call one way or another on that, because we're seeing specifically recently how a lot of these big companies that thought that scale is the answer to unlocking value in primary care to be just completely wrong, right? I mean, Walmart just completely dropped out. So many of the other ones are just dropping out. So you're seeing a lot of companies that are like, ooh, primary care, there's money to be made there, and we have scale, we've got numbers, we've got, we can do this. And it turns out that's not the answer at all. Like my good friend Graham Walker likes to say, they just haven't done the work. They don't understand that this is actually really difficult. And so I know it seems like all the systems are buying up all the private practices, and they're all just being eaten up by some of the larger health systems. And then you've got these even larger non-health systems coming in and buying health systems and things like that. But I think that as the kind of pendulum swings, I think we're kind of, I think there's kind of a pushback to, no, you know what? I want a relationship with my doctor, and I want somebody that I could see for the next 20 years. And so I don't know. I don't know exactly where that's going to head. Yeah.
Awesome. And to kind of go back a little bit to your companies that you lead, kind of CareCo and Previva, kind of what is the story behind both of those companies?
Yeah. So Previva is the service-based care coordination company that I mentioned earlier. So that's been so much fun building over the last 5 years, and bringing in an incredible team and putting the team together, and just step by step by step by step by step. It's been so much fun. The successes, the failures, and it's crazy to think back to when we started building it. I moved down to Pennsylvania to start building out the actual team, which is where I live now. And I started interviewing. So I'm like, okay, we got to bring in employees. So I started interviewing. I'd never hired anyone before. So I started interviewing. I didn't even have an office. I was meeting people at Starbucks, and and I was like, you know what, this is kind of weird. I should probably get an office. And then we got an office. And then my first hire, actually, who's now my chief nursing officer, and she's incredible. It was a total mistake that she came to the interview. She thought that she was interviewing for a totally different company. And by sheer luck, it all kind of came together, and she was incredible. But it was such an interesting time back then, because for me personally, because when you're starting anything new, I mean, you have to be ready to make mistakes. And it's really interesting, because my first hire ended up being absolutely phenomenal. She's really, really incredible. But as I think back, my second hire, my third hire, my fourth hire, my fifth hire, my sixth hire are all no longer with the company. Like, those were all, for one reason or another, not there. So those were all either mistakes or just didn't work out one way or another. But yeah, there's a lot of mini stories there in building that company, but it's been a lot of fun. And now, now we're on a really good track. And then CareCo, like I talked about earlier, was kind of just built off the understanding of care coordination in the space, looking at the opportunity, looking at the pain point. And what's really exciting about what we're able to do is that we're not building this with the end user in mind, like so many startups. We're actually building it with the end user, because they're able to actually test everything. So it's exciting. It's really exciting. And there's a lot of differences between building the two different companies. They're two very, very different types of companies, different types of businesses, different types of teams, different types of business models. But it's a lot of fun. I'm enjoying it.
And could you just give kind of like a 10,000-foot overview? Because the saying is like all politics is local, but it seems like also all healthcare fundamentally is local too as well. How is value-based care and care coordination, like how is it delivered and implemented in Pennsylvania from what you've observed?
Well, I don't think, when it comes to the fundamental methodology of care, that varies very much. So I mean, we, like at Previva, we service companies in, like, I don't know, 8 or 10 states, something like that, and it's all pretty much the same. But Yeah, I mean, in Pennsylvania, we've got some great systems here. We've got Geisinger, we've got Lehigh Valley, we've got a couple others, and each one does pretty incredible care coordination work, and they definitely have risk-based contracts, and they have some value kind of verticals. But there is differences in what we see at Previva is there's definitely differences in the patient demographics and the way that you choose to deal to speak to patients is definitely going to differ. So like patients in New York and New Jersey, they just want to get straight to the point. What do you need? They're not unfriendly, but that is their friendliness. It's like, what do you need? What can I do for you? Okay, here's the answer. Okay, I'll talk to you later. Bye. And then maybe patients in Texas and Florida, and they want to talk a little bit more, and they want to talk about the kids first and things like that. So it's really important. And that's, when we talk about keeping the patient front and center and keeping the patient first, like that's really important to keep in mind that there are differences in the way that you have to approach care coordination because, you're trying to achieve a certain outcome. You're not going to get that outcome without actually having the patient on board. And so that's why it's so important to keep the patient front and center and say, okay, how does the patient want to be talked to? How does the patient want to be interacted with? And that can be just from the, is it phone, text, email, video? Like it could be from that regard, and also just within your actual conversation, who wants to be talked to, how, and keeping that in mind is really important.
Mm-hmm. Awesome. And wanting to change gears to and kind of bring it more to a question of individualism, how would you, Mendel, like to contribute to the AI healthcare conversation moving forward?
Yeah, I mean, I do a lot of panels and I do a lot of speaking, and I wrote a book called Unleashing Value: The Case for AI and Value-Based Care. And what kind of gets me annoyed about a lot of these panels and conversations is that they're all theoretical. It's a lot of panels. There's a lot of good people out there, and I follow them. But there's also a lot of people that are just, people that follow the trend. And they were experts in Web3, 2 years ago, and experts in blockchain or experts in whatever, and now they're experts in AI. And there's nothing real. It's just pontification. It's just conversation. It's fluff. It's air. And what I think is so incredible about what we're building at CareCo is that when I show that to people, when they experience it, they're like, oh my goodness, this is it. This is the future in the present. Like this is an actual, real, physical, presently valuable application for AI. And I think that there's a lot of big bubbles that are going to burst in the next short while, in the next year or so. I did a whole post on LinkedIn about this that I really feel strongly about because you're starting to see it in other industries like the tech industry. Most recently, and the reason why I went on and on about this is because I was personally excited about this company called Rabbit. They put out a piece of tech that they announced at CES a couple months back called the R1. And, he did this whole presentation about how it was built on a unique LLM. It's called an LAM, a large action model instead of a large language model. And explained that how it does, and it's completely unique. And it sounded really exciting. And it was like, this might be kind of the beginning of AI hardware. And then, we're in this stage right now where a lot of the bubbles are bursting, and a lot of the people that are just either their product, just isn't that good, or in some instances, they've completely lied about what they're doing. And so apparently, and my sources are these YouTube videos of some of these tech reviewers, and I linked all the sources to where I'm getting this from in my LinkedIn post. But apparently, the whole concept of the LAM was completely false. It was literally built on OpenAI and Perplexity, and to the point where somebody managed to reverse engineer the code and look at it. And in the prompts to this device, it was instructed to never reveal the fact that it was built on OpenAI.
Oh, wow.
Yeah, so people, and then they ship. See, this is why we're in this period now, because they've actually shipped. And so first you had the Humane AI pin, which was a complete disaster and totally tanked. And then you've got, and now you've got this, the R1, the Rabbit that shipped, and everyone's like, this thing just doesn't work. Nothing works. And then as they start digging into it, it turns out it's one big scam. Again, from the data that I'm seeing, it looks like it's just one big scam. And so the whole thing is kind of falling apart. And I think that's coming for healthcare next. I think there's a lot of companies that are promising a lot of big things, don't actually have a real plan. They don't have a distribution plan. They don't even know if their product works yet. And it's more conceptual. And then on the flip side, you've got a lot of people that they're building some really, really small things. And their danger, the danger there is that, the next GPT update, or the next Claude update, or the next model is just going to swallow them whole. And I think there's a lot of companies that should be very, very, very scared about that possibility. So it's really an interesting time. But again, coming back to your question about what I find super invigorating is that when, like, what we're building, it's real, it's present, it's a huge value, and I don't think it's something that's going away either. And if anything, we're the winners when it comes to the race wars between the models.
Yeah, you brought up something that I've was reading about a while back, when everyone thought like the digital therapeutics were kind of going to be like the thing that's going to solve healthcare, and then all of a sudden you see Wall Street is like pulling out of their investments like left and right.
Yeah.
So that's kind of what it kind of reminded me it was the digital therapeutic space that like, oh, this is going to like save healthcare. It's going to improve patient outcomes and not, but turns out that was false. And it seems like kind of from what I've observed, that we're still trying to figure out fundamentally, how do we successfully implement that next generation of technology company to actually improve those patient outcomes moving forward.
Yeah, look, my take, and I've talked about this really often, is that nothing at the end of the day will change until we figure out how to get the patient on board with the conversation of their own health. For some reason, not for some reason, the way that the incentive structure is built in this country, and specifically as we move to value, and that's why it's a bigger issue as we move to value, is that it's almost like it's my doctor's problem for me to be healthy. And so they get paid in fee for service, they get paid when I'm sick. In value, they get paid when I'm healthy. They get dinged when I'm sick, whatever it is. But the incentive structure revolves around the physician. And especially the more, we want insurances to come down, and Medicare is free for many people. Medicaid is free for many people. And there's just it feels like there's just no incentive for these people for patients, and I'm talking about myself as well, for patients to proactively be healthy. And at the end of the day, the answer to like a lot of the problems is in preventive care. And so we really want to be implementing a lot of preventive care, but in order to do preventive care and getting people out there and go exercise and go eat properly and eat more healthy and stop with the fast food, and we have to figure out how to really get the patients on board with the conversation. And I think the secret to that is understanding individual patients' why. Like, what is important to you? Why do you want to live longer? Why do you want to live healthier? Because we live in a society that's very we get a lot of immediate gratification, and that's what we're used to. We're used to turning on our phone and getting whatever we want. We're used to ordering, clicking a button and the product shows up the next day, if not the same day. We're used to sending an email and getting an answer back right away, and so that kind of trains us to not be able to think in very kind of long-term horizons. I think it's unfortunate. So I think we have to really figure out how to talk to patients in a way that understand their why. And I think that moving away from patient relationships is a mistake, because there's no way that you're going to get to a patient, get really in with them if you don't really understand them, and you're not going to understand them if you don't have a relationship with them. So that's A. And then B, I think that there's a lot of work to be done on combating the unhealthy diets and the obesity issues in this country. There are literally entire departments at every single one of these fast food companies that are dedicated to addicting patients to their food. I've met these people. They're literal scientists, and I mean, it's not a secret. There are scientists that are dedicated to figuring out, that exact amount of crisp and crunch and flavor and needed to make sure that you keep coming back for more. And they're, it's this capitalist society. They're for-profit companies, and that's totally fine. That's fine. But on the flip side, we have to be doing equal work as well. We have to be combating that to a large extent. So I think those would be two good places to start.
Mm-hmm. Awesome. And then my last question for you, Mendel, is like, what is one thing about AI in healthcare that you have the confidence that you understand, but like Congress doesn't get? Like, another way to say it is like, what does Congress need to understand about AI in healthcare?
I haven't I haven't put a lot of energy into looking at what they do or do not understand, because maybe my false misunderstanding, but my conception of Congress is that they just typically don't, and even if they do, they're not going to do anything about it. And it's just, I don't know. The system definitely feels very disjointed and very, very broken, and so it just doesn't seem to be a place to be putting a lot of energy. Um, but I think, because and the other thing is, I don't even think it's Congress. I think most people, most executives, they're lost in between, some like, oh my goodness, they just found out about ChatGPT and they realize that, some sort of concept about AI, or the flip side, they're hearing about, AI robotic surgery and these really cool things that are like in the future. And I don't think there's a lot of people really, really shining a light on just like, here's what this can really do. And the danger with looking at the future is that a lot of that won't pan out, and a lot of it definitely won't pan out in the way that it's being promised. And so what that creates is a mistrust with the entire technology. It creates a lack of interest in pursuing it further. And if we could just focus on, hey, what can I do today that will make my life, my patients' lives, and my staff lives better? Let's just start there. So when it comes to Congress, I would say, educate yourself on some real life. Go experience some real life, um, use cases. I'm more than happy to show anyone what we're doing with CareCo, but there's definitely a lot of use cases out there where this is real. This is real, and it's happening, and there's no question about the positive effect that it's having. But don't get lost in the whole theory. Make it real.
Awesome. And where can people find more about you, Mendel?
LinkedIn would be the best place. So LinkedIn, Mendel Erlenwein, and YouTube, Healthcare Trailblazers Podcast. We just passed 7 million views on the channel, and Spotify and Apple and all the other platforms that it's there.
Awesome. And also, too, at the same time, don't forget to read the AI Healthcare Report that comes out every week. AI Healthcare Podcast, we launch 2 episodes every month. And then as well as at the end of the month, the FDA Roundup, which just kind of goes over the top 5 things that the FDA is looking at here in Washington, D.C. This is Dylan Reed signing off. Thank you so much for your time again, Mendel.